So be like.
Good evening, one and all. Give us some more time. Let us enter everybody into this waiting area. Once again, many are in the waiting area. Give us some more time. Let's enter all into the room. Give us some time. Give us a couple of minutes more. Exactly at 9:30, we will start the introductions and then we will start off tonight's lecture. Give us a couple of minutes more. Okay. We have a pretty big number in Zoom as well as YouTube live showing up. Give us some time. Good evening once again. Welcome to this free lockdown webinar series from Online Dentistry. And tonight is special for Online Dentistry. We have there are two major things that has happened today. We have this is a 300th free lockdown webinar of Online Dentistry going consistently from March 23rd, one day before the official lockdown by Government of India. And the another landmark which have crossed is we have crossed 5,500 participants in our online dentistry website. So that's another landmark we have crossed. And another landmark we have crossed is 1.6K in YouTube. So, but YouTube is like if everybody starts subscribing, it will be definitely more than 5,000. But we have never told anybody to just please subscribe, please subscribe. We never did that. So let me do that from today onwards. Please subscribe if you like, that typical thing in all YouTube videos. If you like our video, please subscribe, click on the bell and all that stuff. We don't like to say all that, but please do that so that we can have a lot of subscription going there. Also, the advantage of you being a member of the YouTube group is that you can get instant notification of all the coming up programs. But even otherwise, you get through your WhatsApp, you get through your website links too. So that should be all right. So that's 9:31. Okay, thank you very much once again for coming in big numbers. We have Joe and Dr. Joby. Are we through with YouTube also? Are we through? Can I start?
Yes, yeah, when you can start.
Yes.
So welcome all once again to the 300th free lockdown webinar series. March 23rd, one day before the official lockdown declared by India government, myself and Dr. Joby decided that, hey, why don't we do a class for our group? That's Online Dentistry Mayo, Online Dentistry Ortho. 12 years into offline 12 years into offline courses, we had two groups who did 3-day programs under us, 3 full-day residential program, morning 8 a.m. to evening 8 p.m. Hectic 3-day programs with banquets, whatever you name it. We had good times, 3 full days. So that two groups supported us. They referred to other friends of theirs and we expanded. We expanded from March 23rd onwards. So Online Dentistry is a firm dedicated to dental education with a motto, redefining dental education. Every topic we do, believe me, every topic we do will have something to do with private practice, something to do with practitioners next day morning in their clinic, in the patient they see next day morning. That is our promise. We don't talk big stuff. We don't talk big theory. We don't talk big articles and journals and all that. We give referrals, of course, but what you can apply tomorrow morning in your clinic. Myself, Dr. Binu Abraham, CEO of this firm, orthodontist practicing in Kochi for the last 23 years, with around 8 people as my specialists, as a team working together, including Dr. Joby as my consultant pediatric dentist for the last 12 years. It's a teamwork going on called as Kerala Dental Clinic. My partner, Dr. Joby Peter, my pediatric dentist, professor and head, Department of Pediatric Dentistry, Malabar Dental College, Kerala. He is one of the most sought after speakers in India at this point of time, and I would say around the world. He has represented multiple firms, multiple organizations, multiple universities all over the world as an international speaker at this point of time. Both of us did this firm together. We have around 10 centers all over India. Delhi, Pune, Mumbai, you name it, it's there. Pan India, we have centers, we have people supporting us. We have conducted offline courses in all these 10 centers right from 2008 onwards. But presently, all the courses, offline courses, stopped due to the COVID, due to the pandemic. We have conducted classes all over India. Some of the pictures, some of the great personalities who attend our program. One of our mentors, Dr. Pushparajan sir, is there, Dr. Raghavendra Shetty. There are many names. There are so many photos which we can share here. Big personalities in dental fraternity who has come all the way down to Kochi, Alua, Kochi, to listen to our programs. Thank you so much for the support given by all these people. But at this point of time, all offline courses suspended due to the pandemic. We have 2 types of webinars going on at this point of time. One is a free webinar for 1 hour. That's one you're attending. You're attending the 300th free webinar, which is a webinar with certificate of participation. All you have to do is register in register in our website. You can watch the program in Zoom or YouTube, but you are still eligible for a certificate of participation. Then we have something called as a paid webinar. These are like 3 to 7 hour huge webinars. Tomorrow we have one from 10 a.m. to almost 6 p.m. tomorrow, completely packed schedule. I'm sure Dr. Joby is right now in his laptop preparing for that, because that's a huge program coming up tomorrow, completely booked and sealed, and a lot of people are waiting for that program tomorrow. That is on non-extraction crowding management tomorrow whole day. We are all pretty busy in that. That's why we have given tonight's lecture job to our guest speaker, Dr. Deepak, so that we don't have much job to do other than introducing the speaker. Then we have many other paid programs also coming up soon. We have a laser coming up. Dr. Sharavanan, who had already done our free webinar on lasers once, and we have a cephalometric tracing basic program coming up. Simple cephalometric for private practitioners, postgraduate, undergraduate students. That's another good program coming up. Those who are still not a member of our WhatsApp group, please note down this number and become a member of our WhatsApp group, because you get instant updates through our WhatsApp groups. Coming up programs is preventive dentistry coming up next Wednesday by Dr. Joby, and next Saturday myself is going to talk about advantages of clear aligner. And then the Saturday after that, we have Hall Technique, the stainless steel crown, and amazing stuff for pediatric dentists as well as general dentists. On Hall Technique by Dr. Surul Babu, that's an international faculty again from Saudi, coming in Saturday after that. All the dates, everything will be updated. Those are all beautiful programs coming up. Paid programs tomorrow, non-extraction management, it's full and sealed. Laser seats still remaining. We are sealing it tonight. The main group is sealed tonight, but there will be a waiting list group. We will have entry for some more people because this is a guest speaker coming in. So we won't have any repeats. So we'll definitely have more people coming in. We will let more people in. We will let you know about that. Cephalometric still open, still not sealed. The group is still open. You can still join. Just have to go to the website, click and enroll yourself in one of the WhatsApp groups. That's what the Pray program. That's it. With these, let me hand over to Dr. Joby to introduce the speaker for tonight. Over to you, Dr. Joby. Thank you.
Yes, thank you. Thank you so much, Dr. Binu, for the introduction. And now, my duty, I hope everyone is safe and sound in your respective place. My duty is to introduce one of my very good friend, to let you tell you, whom I know for the past 4 to 5 years, working with him for the past 5 years. So I don't want that conventional, introduction of a speaker, because I know him very well. And when I told about this platform and I told about what our concept is, because that really made me to think about inviting him for his this lecture, because he has detailed told me about what he's been practicing for the past 13 years or so. So is Dr. Deepak Biryani, who's finished his BDS and MDS from A.B. Shetty Memorial Institute of Dental Science under Rajiv Gandhi University. After that, he is been into practice with almost 13 years of clinical experience, and one person who is especially into TMD and all the implantology, all those things. He does it in a different way. The way that I liked him is, if you present a case to him, the way that he analyzed the case holistically. It's not just the complaint of the patient he attends the entire holistic approach and aspect of it. Even though I work as head of the department in pediatric dentistry, even if a cyst case comes, the interaction, the interdisciplinary approach, he talks about it and how we have to manage. Even maybe it's a dentigerous cyst, it can be just a eruption cyst. The way the protocols that we has to follow, that really opened my eyes that yes, he's a good teacher, good orator, good guide for everyone. That's why we invited him for today's session, because in general dentistry, in our general dental practice, there are lots of myth and dilemma about TMDs there. If you look into brochures, if you look into websites, there are so many websites and brochures. There is that TMD 150 hours, 250 hours, that this they talks a lot of great things. But when we go to the review of the same people who attended, what we get is, yes, it's a nice program, you get a degree, but you can't apply practically. When you talk about the patient sitting in your dental chair, you have a lot of knowledge, but how to implement, you get stuck there. That's where I want to introduce today's speaker, Dr. Deepak Biryani. He is a professor and head of the Department of Oral Medicine and in Malabar Dental College. I told you we work together. So to his credits, if I want to talk about is, he has got numerous publications talking. He has does lectures. He's exclusive courses also. He's a pure clinically oriented person who teaches postgraduates in a very clinically oriented way. And I have personal experience of what he's doing in the department also. With this, let me welcome Dr. Deepak sir. Welcome, Deepak sir. The stage is for you. All the best.
Good evening, everyone. Thank you for those kind words of introduction, Jovi sir. At the outset, let me thank the organizers of online dentistry for giving me this opportunity to speak on my favorite topic. Talking about this topic today, I will make an attempt to explain the most important concepts, the most important decision making, and the most important treatment protocols for TMDs, which can be done at the level of general dental practice. I will request the listeners to note down the takeaway points I'm giving, and also to note down the points where they have confusion or they want to know more into more details of it, so that we can always talk about it later after the presentation. So let's get on with it. The human masticatory system is a complex system but it's a very unique system. It's a product of millions of years of evolution. The most interesting thing is the intricate balance between the bone, cartilage, ligament, muscle, and teeth, and how they work in unison to create this perfect masticatory system. But this masticatory system is not all that perfect. It is loaded by multiple external factors. For example, mastication, stress, trauma, parafunction, etc. These all things load the TM joint. If this external load which is given to the TM joint is more than the load bearing capacity of the masticatory system, then what results is called as TMDs or temporomandibular disorder. What do you mean by temporomandibular disorder? When I say TMD, it means the functional disorder of the bone, ligament, muscles, and the cartilage associated with TMG. During my practice, I have found some very, very interesting facts which I would like to share with you all. 95% of my patients were females. And we can explain this, we can accept this because females have estrogen hormone which laxes the ligament and allows for that little play which makes them different from the male, and hence because of that little play they are more prone to TM joint disorders as compared to male. Also, the researchers have said, has told that the emotional stress bearing capacity of females is lesser than male. So that is why they are more prone to TMDs. The second fact, the second interesting fact which I found, which is very important for us, is occlusal discrepancies accounted for 85% of my cases. Now this is also acceptable. Little bit change in occlusion can load our joint massively and in long term can result in breakdown of masticatory system, one or the other component of masticatory system resulting in TMD. The next fact is 70% of my cases reported emotional stress. Now, this is also acceptable because we know that stress causes muscle hyperactivity, and in long term, this continuous muscle hyperactivity can result in breakdown of TM joint resulting in TMDs. But what one fact I could not understand or could not make out, or let's say it was the most disturbing of all the facts which I had, is 80 to 85% of my TMD cases were iatrogenic. That means they were dentist induced. What does that mean? The dentist who has called me for checking or has referred me the TMD case, somewhere I could make out that that dentist itself has induced TMD somewhere. This made me think that there is something wrong. Let me explain this scenario by this case. This 39-year-old female came to me with the complaint of pain in the left TM joint. Now, on taking a detailed case history, I realized that this patient had been to another dentist with a complaint of pain in 3/7, for which the dentist advised a root canal treatment. The root canal was done, the pain was gone, patient was happy. The dentist then further told her to go ahead with the crown, and she said, okay, she was happy. The crown was placed. Next day, she realized that there was discomfort while eating on the left side. So she went to the dentist and said, I have discomfort on the left side. So he grinded that teeth and said, now you will be fine. So she goes back and she again starts chewing, and she realizes the next day that still that discomfort persists. And now that discomfort is also associated with pain in the tooth. So she again goes to the dentist. Dentist again trims the tooth and says, now you should be fine. She goes back and she again starts eating, but she realizes she's not able to eat from the left side, and she starts eating unilaterally from the right side. And after some days, she realizes that the pain, which was only on the tooth, now has gone to the left TM joint and has gone to the head, causing a constant headache and also resulting in neck pain. She is not able to eat, she is not able to sleep, and there's constant headache, which is giving a lot of anxiety. Now with this, she goes to the dentist again, but look what dentist says. Madam, it's a TM joint problem. There is nothing wrong with the tooth. I have already adjusted your tooth, and it's a TM joint problem and you have to go to a specialist. And that's how she lands up with me. Now I do a thorough examination of this patient. I do the intraoral examination. I do the TMJ examination, the muscles of mastication and other muscle examination. And I realize that this patient has got multiple issues now. The teeth, severe pain in the teeth. There were involvement of multiple muscles, lateral pterygoid muscle, temporalis and trapezius was involved. TMJ involvement, she had disc displacement without reduction. And due to the constant pain in the neck, her neck position has shifted towards the left side. She was unable to eat, unable to sleep, and constant headache and neck pain means in short term, there was a complete collapse of masticatory system. Question arises, where did the dentist go wrong? To find out where did the dentist go wrong, I used our humble articulating paper and I tried to find out. And to my surprise, look what I found. I found that the functional cusp of the mandibular arch, that is the buccal cusp of the mandibular teeth, are called as a functional cusp. They were all coming in contact when I checked it in the maximal intercuspation. That means that the dentist did the job well. He did the job well. He checked the maximum intercuspation and he reduced the crown. Then the question arises, what actually went wrong? How a simple dental treatment led to the simultaneous involvement of tooth, TMJ, muscles, and headache, and most importantly, how to manage. Now, to answer these questions, I'm going to introduce certain basic concepts of TMDs, which I feel is a must for all dentists. Number one, the concept of disocclusion time. Now, this disocclusion sounds very complicated. It is not. Let's see what is occlusion. Occlusion is nothing but the way in which the maxillary teeth and the mandibular teeth comes in contact, and each individual has its own occlusion. What is disocclusion? The disocclusion is the way in which the teeth goes apart. Now, the teeth doesn't go apart only in one way. The way we checked, or way the dentist checked, that is opening and closing. It goes apart in lateral protrusive manner also, and in anterior protrusive movement also, as you can see in this picture. So what is more important? Is it occlusion or is it disocclusion? Occlusion is as important as disocclusion, but the problem is most of the dentists just give importance to occlusion. They don't think or care about disocclusion. Most of the time they are lucky and hence the patient doesn't come back, but they should have a detailed concept of disocclusion. So what has happened here in that case? I will be referring to this case throughout the presentation so that I will be able to answer the questions which we have raised. So I went ahead and I did the lateral protrusive movements by checking the canine guidance and the group function. Okay. And then I went ahead and did the protrusive movements of the mandible. Okay, that is, I tell the patient to protrude the mandible, and when the mandibular teeth comes in, the mandibular anterior teeth comes in contact with the maxillary anterior teeth, all the teeth should get disengaged. This is the anterior protrusive guidance protocol, or say the rule. Look what I found. When I did this, I found that, I found that the crown has got a lot of eccentric contacts as compared to the other teeth. What does that mean? That means that the dentist has unknowingly increased the disocclusion time. That means the teeth in this, when this tooth was coming in contact, the 3-7, the crown containing tooth was coming in contact with the opposing tooth, it was taking more time to disengage. This is called as increased disocclusion time. So the thing is, when we reduce a crown, we actually reduce the disocclusion time. So I went ahead and did that. This was the main mistake done by that dentist. What is the takeaway point for all of you here is no dental procedure should increase the disocclusion time. How to make sure of that? You can make sure of that by after doing any dental procedure, especially restoration or crowns, what you put, check for canine guidance or group function. So canine guidance and group function is almost the same term. Canine guidance is when the mandibular canine comes in contact with the maxillary canine, while the lateral excursion, all the teeth should disengage, but it doesn't happen in maximum population. What happens? The premolar cusps also comes in contact. So the rule says that is called as group function when more than one tooth comes in contact. So the rule says that when any cusp beyond the mesiobuccal cusp of molar comes in contact, it has to be reduced. Otherwise, it gives a lot of forces to the TM joint and to the masticatory system, which can result in TMDs. So for after doing, in a simple term, after doing any dental treatment, make sure that you check the canine guidance and you check the anterior protrusive guidance. And if there is any increased disocclusion time, you reduce it. Concept number 2, masticatory system always tries to achieve maximum efficiency. What does that mean? Our masticatory system is very smart. It calculates. If it calculates that the chewing efficiency on the right side is lesser than the chewing efficiency of the left side, it will automatically shift the food to the left side and patient starts the unilateral chewing. Okay. A healthy masticatory system is one where there is bilateral chewing. Now, due to some reason, maybe induced by us, as in this case, which I showed you, due to the occlusal discrepancy, patient was not able to eat from one side and she started eating from the other side. And when the patient starts chewing unilaterally, the load on the TM joint and the muscle and the masticatory system as a whole increases. And if the masticatory system is little weak or this external load is heavy, it can lead to TMDs. So what is the takeaway point here? After any treatment, make sure that patient is chewing bilaterally. How do you do that? I have made a rule in my clinic and I have told everybody in the clinic, you do any dental treatment, anything, whether an orthodontic treatment or a restorative treatment or an implant treatment, you will tell the patient that the ideal way of chewing is eating bilaterally. If you feel that you are not able to chew on both the side and you are chewing only from the left one side, please come back to me. I will work upon you till you achieve this efficiency. Concept number 3, TMDs always has multiple etiologies. What does that mean? As I said, our masticatory system is an intricate balance between the bone, tooth, ligament, cartilage. If one component breaks down, the other components will take the load. As in our case, earlier only the tooth component was involved. But if the external load is too much, then the next component also can break down and the next component can also break down. And when the patient will present to you with TMD, he or she will have multiple etiologies. That means here the teeth was involved, the muscle was involved, and the TM joint was involved. What is the takeaway point here? Always expect then when a TMD, you are coming across a TMD case, it will have a multiple etiologies. And so your treatment also will be multifactorial. No single treatment can treat TMD to its entirety. You have to use simultaneously multiple treatment modalities to treat TMD. Okay. So how to achieve it? So I will be talking about this treatment modality a little later in the presentation, but let me tell you, there are 4 main treatment modality with which you can treat a TMD patient at the level of general dental practice. That is pharmacotherapy, occlusal splint therapy, physical therapy, and physical self-regulation techniques. Concept number 4. Let's finish with our concepts first, then we will go into the other aspect. The concept of orthopedic stability. What do you mean by orthopedic stability? Very simple. An orthopedic stable position is that where all the muscles are relaxed. And what is that position? Look at this black line. This is that position. technically speaking, if a condyle is pitched against the intermediate zone of the articular disc and the condyle and the articular disc is pitched against the most anterosuperior position of the glenoid fossa, is called as the orthopedically stable position. This is nothing but centric relation. We all know how to take centric relation. Here I am showing a way of taking centric relation, which is the most musculoskeletal stable position. How to do it in a clinic? I am using a modeling wax here, but ideally you should use a bite registration wax, but you can manage with modeling wax as well. So what we do is we just adapt the modeling wax to the cast which is already made, and then you make the patient sit comfortably, extend the neck, adapt the wax over the maxilla, and then the most important point, adapt your fingers along the lower border of the mandible and your thumb just above the chin. Push the mandible backwards and upwards and close the mandible. Try to guide the mandible and close it, and you will be able to achieve centric relation. Now it's an art, it will come with the practice. We all have learned this, but we have to practice it to achieve it. I will tell you the importance of centric relation little later. So the takeaway point here is, if your dental treatment does not provide orthopedic stability, it will lead to TMDs. How to achieve it? When you are making a CD, you take a centric relation. But when you are making an RPD, especially with distal extension, long span bridges, full mouth rehabilitation, even night guards, I'll talk about night guards a little later, all the common things what we do in the general practice I'm going to talk about, and orthotics. Whenever we make such things, whenever we work on these things, make sure that you take an interocclusal record at centric relation. Take that record along with the cast which you have made, send it to the lab. The lab will fabricate the prosthesis as per your interocclusal record, which is at centric, which is an orthopedically stable position. Concept number 5. This is a relatively newer concept, a very important one, and this is going to be the future of dentistry. I'll explain to you how. Muscle has the maximum influence on masticatory system. What does that mean? Muscle is the king of masticatory system. Muscle determines the final position of the mandible. Muscle determines the final position of the skeleton. So we have to respect muscles. The proper body and the head posture is a result of precise and complex tonicity and interaction of different muscles. Let's see how these concepts relate to our case. Now, we introduced the occlusal discrepancy in that patient, which resulted in breakdown of one muscle. The load continued, resulting in the breakdown of other muscles. If this position had continued, it might have resulted in inability to walk fast, inability to balance the body. Let me show you how it happens in a diagrammatic way. Now, this is the patient who came to us with a tooth problem. And that tooth problem increased the load on the masticatory system, resulting in breakdown of multiple muscles. Now, the patient came to us when she had a neck issue. There was the neck had got tilted towards the left side, if you remember. If we were not to treat them, this problem would have continued inferiorly, involving other multiple muscles, which would have resulted in the change in the center of gravity of the body, resulting in what is called as a hip drop gait or Trendelenburg's gait. So this also could have happened just by a simple occlusal discrepancy. What is the takeaway point here? Consider muscular stability in every dental treatment performed, and this is the very basis of neuromuscular dentistry. Okay, I will not go into the principle of neuromuscular dentistry, but I will introduce a simple concept of neuromuscular dentistry by two devices, the T-scan and electromyography. Let me just put this insight into you. What is a T-scan? A T-scan is a device, as you can see on the right side, it has got sensors. When a patient bites on it, it records the precise contact. So for example, if you have done a restoration or you have put a crown, you use this T-scan to find out if there are any prematurities. It will tell you very accurately. It can also tell you the amount of force given, and hence you can adjust your restoration as per T-scan very, very precisely. But still, T-scan doesn't measure muscle activity. You also have to measure muscle activity. So that you can do by integrating a EMG with T-scan. So what does an electromyograph does? It measures the muscle tonicity. So when a patient bites, it measures the muscle tonicity and tells whether a muscle is hypertensed or not. Because you remember, the muscle is the king of masticatory system, and we have to keep the muscle at a optimal situation or optimal, position. Let me give you a small insight about the orthodontic practice which happens in India. Most of the orthodontic practice relapses, and we maintain the orthodontic treatment what we have done by giving the retainers, mostly the fixed retainers. Now, as per the leading orthodontists in the world, the main reason for this relapse is an orthodontist does the job without calculating the muscle tonicity. So he just changes the occlusion, he never measures the muscles. If an orthodontist works, changes the occlusion by measuring the muscle activity and keeps the occlusion at a position where the muscles are relaxed, no relapse will take place. But what should we do? 99% of clinics in India does not have T-scan and electromyography. So what is the alternative we have? We have an alternative of T-scan, and that is the humble articulating paper. Now, using an articulating paper is an art. You should know what are the different types of articulator, when to which articulating paper has to be used. Articulating paper usually comes in blue color and red color. The blue color is to check the posterior eccentric movements, and the red one is to check the anterior movements. Okay, so articulating paper should be used after every dental treatment to make sure that you have adjusted. What is the alternative of electromyography? There is no alternative of electromyography. The closest I can think of a method is the centric relation, which I have talked about. So try to incorporate centric relation, try to measure centric relation in most of your dental treatment. That will keep the muscles at a peaceful state or at a relaxed state. They will not be in an hypertonic state. Concept number 6, the last concept, the equations of TMD. This is a very, very important equation. And as per me, if you understand this equation, you will be able to treat 90% of TMD cases. What is this equation? Normal function. What is the normal function? Chewing is the normal function which loads the masticatory joint or the masticatory system. Can we reduce this? We can't. This has to continue. But there are other events which also loads the masticatory system, like occlusal factors, emotional stress, trauma, etc., etc. If the sum total of these two external events is less than the physiological tolerance or the load bearing capacity of the masticatory system, no TMD disorder happens. Let me show you in a different manner. Look at Jim Carrey. He is chewing to glory. A trauma happens to him. Okay, but his physiological tolerance is much, much more than the total load given, and nothing happens. So he just laughs off. But look at the other scenario. If the normal function and the event, the load given to the masticatory system is more than the physiological tolerance, then the TMDs occur, like in this case, where the trauma is too much and hence Jim Carrey suffers with TMDs. So this is a simple way of seeing why TMD disorder happened and what should we do about it. So what is the takeaway point here? Look at the equation down. You can manage TMDs by two ways. Number one, look at the yellow arrow. You can diagnose the events and reduce it. That way you will reduce the load, or you can increase the physiological tolerance of masticatory system. Okay, this is another way by which you can avoid TMD, because you are increasing the physiological tolerance of your masticatory system. How will you do that? How to achieve it? For this, you have to gain the skill to diagnose what are the events which causes, which loads the masticatory system. The most common one is occlusal factor, then emotional stress, then trauma, then deep pain input, and then the parafunctional activity. You have to find out these events, and if you can eliminate it, eliminate, or you have to at least reduce it. And the second more important thing, what you have to do is increase the physiological tolerance. I will be talking about physiological tolerance a little later in the presentation, and how we go about strengthening our body and strengthening our masticatory system. With these concepts in mind, let's go to the management of TMDs. But before we go into the management of TMDs, a dentist should have skill to do a detailed case history and find out the symptoms associated with signs, do the examination, and come to diagnosis. To make this thing simpler for the listeners, I have made 6 decision making which you can do. You have to make certain decision. The decision number 1, whether the pain with which the patient has come is a physical pain, or is it a psychological pain, or is it both? In most of the cases, it is going to be both, and you should be able to differentiate between the two. Decision number 2, whether to treat this case, whether not to treat this case, or whether to treat the case with the help of other specialists. Okay. There are certain cases which you cannot treat. For example, some TMDs are a part of fibromyalgia. So if the situation is very bad, you have to send it to a neurophysician first. Sometimes a TMD is a part of emotional state like anxiety, depression. In that case, you have to take the help from the psychiatrist. So if you feel that the symptoms are not much, then you can treat such patient with the help of other specialists. So this is a second decision which you have to take when you go about treating TMDs. The third decision, once you have decided that you are going to treat the TMD, you have to decide what kind of TMD it is. Is it the intracapsular disorder or an extracapsular disorder? Now, what is an intracapsular disorder? On the upper side, this upper image, you can see, on the upper image, you can see a white capsule. This is nothing but capsular ligament which covers the TM joint. Everything inside this capsular ligament along with this capsule is intracapsular. So any disorder associated with them is called as intracapsular disorder. And everything outside is extracapsular, and that is nothing but muscles. So the intracapsular disorders or the extracapsular disorder or both. Now, if you have an intracapsular disorder, what kind of disorder it is? Is it an inflammatory joint diseases, for example, capsulitis, retrodiscitis, or arthritis? Or is it an internal derangement of TMJ like disc displacement or disc dislocation with or without reduction? You should be able to decide this as well. I will tell you the tools how to decide this. Let's go to the decision number 5. If there is an extracapsular disorder, then which all muscles are involved? Is it the muscles of mastication, the neck muscles, or the back muscles? You have to have the skill to evaluate all these muscles. And the decision number 6, once you have made your diagnosis, you have to choose which therapy to adopt. As I said, there are going to be multiple therapies adopted simultaneously, and that only can treat TMDs. So once these decisions are done, for taking these decisions, I have devised 5 tools. Not that I have designed, but these are the 5 tools which you can use for decision making, and they are easily available at the general dental practice, or you can acquire it easily. Let me tell you the 5 tools with the help of which you can take those 6 decisions which I discussed. Tool number 1, questionnaire. Now, there are a lot of questionnaires already available. What I have done is I have made a 30 question questionnaire, okay? And whenever I suspect a TMD patient has walked in, I hand over this questionnaire and they fill it. Each question has been given a score. So what I have to do is to calculate the score, and it helps me to distinguish between the psychological pain and the physical pain. It helps me to distinguish between the personality traits with which the patient has come and which I can treat. These are the common personality traits with, even we suffer: perfectionist, compulsive, dominating. So these are the personality traits which we can treat. So the questionnaire helps us to find out what we can treat, which all patients we can treat, and what all patients we cannot treat, like the emotional state. There are patients which will come with anxiety, depression, history of physical or sexual abuse, and secondary gain. These patients you cannot treat by yourself. You need the help of psychiatrists to treat such patients. Questionnaire not only helps in that, it also helps us to find out a lot of other things associated, like parafunction or the presence of other diseases like fibromyalgia. So questionnaire is a very, very important tool. Tool number 2, we are all aware of this tool, TMJ examination. We all have to develop the skill to examine TMJ. Okay. You have to know what is an extra-auricular examination, by which you can diagnose capsulitis and synovitis easily. You should know what is intra-auricular examination, and that will help you to diagnose retrodiscitis. You should have the skill to find out how the mandibular movement takes place. You should have the skill to auscultate the TM joint and find out whether there is a disc displacement with reduction. As in this case, you can see the mandible is going on the right side and then coming in the center, and the same thing is depicted on the right side video, which is a video of a cadaver. And you can see in the picture how the mandible goes to one side and comes back. This is deviation of the mandible. We see it in disc displacement with reduction, and we have to distinguish it with disc displacement without reduction. The case which I showed you before, this patient is not able to completely open the mouth. The jaw is going, or the mandible is going only to one side and getting stuck. The disc is not getting reduced. She is suffering from disc displacement without reduction. Tool number 3, you should have the skill of doing the muscle examination. And when I say muscle examination, it's not only muscles of mastication, but the neck muscles and the back muscles as well, because you may find trigger points in multiple muscles. There will be mostly multiple muscle involvement. And by doing this muscle examination, you can find out which all muscles are involved. Tool number 4, the concept of end feel. Okay. Now this concept may be new to you. Let me explain to you. Whenever a patient comes to you with restricted mouth opening, you can find out the reason for that restricted mouth opening is a hard tissue like articular disc or bone, or is it a soft tissue like muscles. So what you have to do is tell the patient to open the mouth as much as he can, and then use the finger like I'm showing it in the video and try to open it a little bit more. If there is a little play, if it gives in, then it is due to the soft tissue like muscle. If it doesn't, then it is due to hard tissue. So you can differentiate between the soft tissue or the hard tissue component by using this concept of end feel. Tool number 5, separators. What are separators? Separators are those devices which prevent the complete closure of the jaw. I use ice cream stick as the separator. Now look at this patient. The patient is having pain on the right TM joint. So I am using the separator and I tell the patient to close the mouth. Just by doing this, I can differentiate between different type of muscle. It helps me to differentiate between the muscle and the internal derangement of the TM joint. For example, the TM joint is painful, but at the same time, superior lateral pterygoid is also painful, is also involved. They are situated at the same position. How will you distinguish between the two? You can use a separator. When you chew on the separator, the superior lateral pterygoid will not get complete contracted. So if the pain disappears when you use a separator, that means it is the superior lateral pterygoid which is involved. But if the pain doesn't get disappeared, then it is the joint, it's an intracapsular disorder. So separator is again a very, very important tool which will help you to distinguish between intracapsular disorders and extracapsular disorders. Now, I hope I am not running away. I have limited time. Please note it down. If there are any doubts, we will, go into details of it. Now, we have discussed the concepts of the TM joint or the TMDs. We know the decision making and we know the tools to make those decisions. Now we are ready to talk about the treatment modalities. I am going to talk about 5 treatment modalities which can be done at the level of general dental practice and which will help you to solve maximum number of TMD cases. The first treatment modality, functional manipulation of the jaw. What is functional manipulation of the jaw? Functional manipulation of the jaw is the process of maneuvering the mandible to achieve certain targets. What are the targets you can achieve by maneuvering the jaw? There are 3 targets you can achieve. Number 1, you can stretch the lateral pterygoid muscle. Why it is important? Remember that the lateral pterygoid muscle is the most common muscle which gets involved in TMDs. Patient will come to you with painful lateral pterygoid muscle which is under contraction. You can relax it. Now remember that how does a muscle function? The muscle functions by contraction. So you somehow, if you can release that contraction, it will relax. How can you release the contraction? Either you can use a muscle relaxant which dulls the brain and relaxes it, or you can stretch that muscle and it will relax. A patient comes to you with lateral pterygoid muscle, you manipulate the jaw, immediately you can relieve the pain. The other targets which you can achieve by manipulating the jaw or by doing the function manipulation is you can reduce the disc. For example, the case which I discussed, the disc is getting locked. The disc is dislocated and it is not reducing. You can very easily reduce the mandible by pushing the mandible down. Automatically, the retrodiscal lamina will pull the disc back. So when you do that, immediately the pain of the patient will disappear and the deflection will become deviation. Patient will be relieved of the symptom and she will gain a lot of confidence in you. Third thing, reducing the condyle. If the patient has dislocated the condyle, she will or he will come with an inability to close the jaw. By maneuvering or by doing the functional manipulation, you can reduce that condyle. And the simple way of reducing a dislocated condyle is just push back posterior and upward, and it will go. Now, this is also a skill which all dentists should have, and it will give you great rewards. Modality number 2, pharmacotherapy. The most common therapy used by all the general dentists, and this is the least common therapy which I use it. That's because pharmacotherapy has got a lot of side effects. It is important initially. It should be given not more than 5 to 10 days because it has got a lot of side effects. So, but still, I will discuss about it because it is important in the initial stages. So NSAIDs, there are so many NSAIDs. The most good one or the one which I like is a combination of diclofenac sodium and paracetamol. In fact, this combination is good for any musculoskeletal pain. It works, but it has a side effect. It causes a lot of gastric irritation and there is liver toxicity. So it should not be used for a very long time. Muscle relaxant. There are a lot of muscle relaxant. My favorite one is chlorzoxazone. It's a centrally acting muscle relaxant and it works the best with combination with diclofenac sodium and paracetamol. In combination, these 3 works very, very well. My other drug of choice is diazepam. It's an excellent drug. It reduces the anxiety of the patient. It relaxes the muscle and it induces a good sleep. The problem with diazepam is it is very addictive, but it's a wonderful drug available as calm pose. You can use 5 milligram for 5 to 10 days to relax the patient and it will really help a lot. I do use tricyclic antidepressants also. Now, the tricyclic antidepressants, if used in a smaller amount, that means in the lesser dosage of around 10 to 25 milligram, doesn't act as an antidepressive. Okay, so it is safe. Amitriptyline given 10 milligram is a wonderful drug, and it initiates good sleep. Okay, the sleep cycle improves and the quality of the sleep improves. So the patient's sleep is very important for us because sleep is the natural muscle relaxant. So the patients with TMDs where they are having sleep abnormalities, we can give TCA at a lower dosage. Occlusal modality, the treatment modality number 3, occlusal splint therapy. This is my favorite modality. Why? Because I can eliminate pharmacotherapy with the help of this. Only thing is we should know how to make a good occlusal splint. When I say occlusal splint, I'm talking about orthotic. What do you mean by orthotic? An orthotic is a prosthetic appliance which, when worn, gives us the orthopedic stability. That means it keeps the musculoskeleton in a very, very stable position. What are the different types of occlusal splint? There are basically two different types of occlusal splint for all practical purposes. Muscle relaxing appliance, otherwise called as jaw stabilizing appliance, and anterior positioning appliance. Now, I have colored anterior positioning appliance as red because it's a very dangerous appliance. I have seen dentists giving anterior positioning appliance without having any knowledge of it. They just get over the counter TMJ devices and give, or they give it to the lab who has no idea, and they land up giving this anterior positioning appliance. It's a very, very, it can be used, but you should have knowledge for it, because when you use an anterior positioning appliance, you place the mandible in prognatic position for a very long time. If it is used for a very long time, it can cause the permanent contracture of inferior lateral pterygoid muscle, resulting in permanent malpositioning of the jaw. So anterior positioning appliance, if at all used, should be very, very short duration, and it should be very, very observant about it. At this stage, I will not recommend any one of you anterior positioning appliance. If you are just starting with TMDs, I will advise you muscle relaxing appliance. Now, what is a muscle relaxing appliance or a jaw stabilizing appliance? Now, it is called as muscle relaxing appliance because here, as I told you before, we record a centric relation. So we make sure that you have recorded that orthopedically stable position, and then you are making the appliance. Okay, I already talked about centric relation before, so I will not go into details of it. Let me tell you the disadvantages of centric relation. Not in all patients you can take centric relation, because in centric relation you push the mandible posteriorly. I hope you remember that video. You push the mandible posteriorly. If the patient is having retrodiscitis, that is inflammatory joint disease, or acute ADD, that is disc displacement without reduction, when you push the mandible posteriorly, they will have acute pain and they will never give you this relation. So you can never achieve centric relation in certain patients of TMD. So what you should do? At this point, I introduce a relatively newer concept of not newer, it's an old concept but not taught about. It's a concept of neutral position. That means recording the jaw relation at neutral position. Okay, what is it? Instead of pushing the mandible posteriorly, we reposition the patient. We reposition the patient, as you can see in this picture, 10 degrees above the horizontal plane or the floor. Okay, and then we adapt the wax. Here I'm using a bite registration wax. This is the bite registration wax. This is much better than modeling wax because it is much, much more stable and it stays in its position for a very long time. It doesn't loses its integrity. So once you have adapted this wax, you place it over the patient, like at the in the maxillary region of the patient. Make sure that patient's neck is extended, and then you maneuver the tongue. You tell the patient to touch the tongue to the palate and roll it back and close. And you don't push the mandible, you just guide the mandible and close the jaw. And this is how you record a neutral position. Once you have got this interocclusal record, you can send this along with the cast for fabrication of the occlusal splint. So neutral position, I'm not going into too much detail of neutral position because it will be out of context of this lecture. Maybe we will talk about it sometime later. Which material to use? There are so many materials available in the market: soft splint, IO clap, Valplast, dwell laminates. But for all practical purposes, my favorite is clear acrylic. Why? Because you can modify clear acrylic. You can add acrylic, you can reduce acrylic, you can do whatever you want with it. So acrylic remains the best material to use according to me. Which occlusal splint to give, maxillary or mandibular? Each has got its own advantage. Maxillary occlusal splint is more stable. It does not hinder in the speech. It does not produce too much of saliva, okay? But it is not aesthetic. So most of the younger people, we can't give it. Mandibular, on the other hand, produces a lot of salivation, difficulty in speech, retention is poor, so sometimes you have to extend it even to the gums, but it is highly aesthetic. So, you know, in younger patients, we can give mandible to the maxillary. Whether to choose a partial occlusal splint or complete occlusal splint. Always and always make a complete one. Why? Because when you make a partial occlusal splint, some teeth will be coming in contact and some teeth will not be coming in contact. So those teeth which are not coming in contact may over erupt. Number two, the teeth which are coming in contact take the entire load of the masticatory system or the entire external load, and hence it can result in breakdown of one or the other component of the masticatory system. So by giving a partial splint, you may be doing more harm than good. Okay. Next, how to decide the thickness, how to decide the extension. Now, a thickness of an occlusal splint depends upon the age of the patient, upon the gender of the patient. But for all the practical purposes, 2 to 4 millimeter thickness posteriorly and anterior adjusted accordingly should be given. Okay. Extension, what should be the extension? Now extension depends upon the retention. If you are giving a maxilla, you can keep less extension. You can extend the splint up to the middle 1/3 or the cervical 1/3. But when you are giving a mandibular occlusal splint, you have to extend it down at least till the cervical 1/3 or even into the gingiva to have the better stability. How should be the occlusal surface of the splint? Make sure that the occlusal surface of the splint is flat. If it is indented, then it can prevent the laterotrusive movement and can result in TM joint problem. Okay, and make sure that the functional cusp of the opposing arch is coming in contact with the flat occlusal plane. I will show you how to go about it. Once you have got the splint, the job is not even half done, because the splint which has come from the lab will never be accurate. Okay, you have to make it accurate with the help of articulating people. So you will use a blue articulating paper for posterior eccentric movements or posterior teeth correction or posterior splint correction, and the red one for the anterior splint correction. And then you go about doing the selective grinding of the occlusal splint till you get a situation wherein the opposing functional cusps are in contact. All the opposite functional cusps are in contact with the flat occlusal plane. What if you don't do that? If you don't do that, then the tooth which are left behind may get over erupted. I hope you are understanding what I'm saying. Okay, I will show you also a night guard which I gave, like an occlusal splint, a stabilizing splint I gave as a night guard, and how it looks I will show it to you. But before that, let me talk a little bit about night guard. Now the patients requiring night guards are very common. They come, you see the wear facets and you decide that patient has got bruxism. What do? Most of the dentists go ahead, take an impression and send it to the lab. So lab usually makes a soft splint and send you back. Look at this soft splint. It has got a lot of indentation, number one, which is not good. Secondly, only the posterior teeth are coming in contact. There is no anterior contact. So what happens when patient wears this splint and bruxes at night? A huge amount of load is given to the posterior teeth only, which creates a pivot, and that can lead to breakdown of the masticatory system. Okay, first of all, never give a soft splint. Let me tell you, when you normally bite, you create a forces around 150 to 200 kgs on a single tooth, depending upon the gender. But when you brux, you create a force which is as high as 300 to 350 kgs. No soft splint can survive that after some time. Make sure that you are giving a hard occlusal splint always. And the night guard should be an orthopedically stable device. That means it should be a stabilizing splint. Look at this case. This case was actually an MBBS student who had bruxism, and she also developed TM joint problems. So we gave them a maxillary occlusal splint. Okay, now look carefully. Once the splint is delivered and when the patient bites, all the functional cusps of the opposing arch. Now I have given a maxillary occlusal splint, and to increase the retention, I gave Adams clasp along with the maxillary occlusal splint. Now, if you see this picture, all the buccal cusps of the mandibular teeth, which are the functional cusps, are in contact with the flat occlusal plane. This is how you should give an occlusal splint, and this is how you should give a night guard also. An ideal night guard is very difficult to make. Doing a selective grinding is an art. Usually I do a hands-on course on making an occlusal splint. It's a very, very important skill to have. Okay. Coming to the next treatment modality, physical therapies. What are physical therapies? Now, physical therapies are certain therapies. Let me tell you, why do we give physical therapy? First of all, they are given for two purposes. Number one, to relax the muscle, and number two, to eliminate the trigger points. Now, what are trigger points? Trigger points are those hyperalgesic or painful points within the muscles which have algogenic substances like pain causing substances in it. Okay, so these are those myofibrils which are in the state of constant contraction and produces pain. So these are called as trigger points. Okay, and whenever TMD patient comes, they will be having trigger points in multiple muscles. It's your skill to find out those trigger points and eliminate them. You can eliminate them by using these physical therapies. So usually the most common, there are so many types of physical therapies, but I am telling the physical therapies which you can use at the level of general dental practice. Thermotherapy, massage therapy, coolant therapy, and muscle stretching, all done together 4 to 5 times a day within a week will help you to eliminate trigger points. But there are some trigger points which are very, very stubborn and that they don't go. And then you can definitely eliminate them by giving trigger point injections of LA. Usually I use an insulin needle to give those, local anesthetic shots to relieve those trigger points. Okay, coming to the last treatment modality. Till now, whatever treatment modalities I have talked about helps you in treating the TM joint or TMDs. But if you stop those treatment, there are chances that TMDs can come again. What you can do that the relapse of TMD does not happen? For that, there is only one therapy. And this is a very, very important therapy, very difficult to achieve. Physical self-regulation technique. This is a procedure by which we increase the physiological tolerance of the body. Okay. How do you increase the physiological tolerance? Now, this is I go about finding out everything about the patient, what time they get up, what time they sleep, how much they sleep, what they eat, how many times they are eating, whether they are exercising or not. So you have to actually go about disciplining the lifestyle of the patient. In these things, the headlines only I can tell you at this point, muscle strengthening is one of the main things. Remember that muscle is the king of masticatory system, and important thing about muscle is you can build. When you go to the gym, you say, I'm building body. What you are building? You are building muscles. You cannot build skeleton. So good thing about muscle is you can strengthen them. Muscle strengthening, very important. Posture improvement. How do a patient sit? How do they sleep? How do they walk? What is the right way of doing it? We introduce this to them. Sleep, very, very important. Sleep is a natural muscle relaxant. We know that sleep boosts immunity. It is very important that a patient with TMDs sleep well. So we analyze their sleep cycle and help them to sleep better. We analyze their chewing and mastication and help to improve it. Basically, we do it by telling the patient to develop the habit of chewing bilaterally. We introduce a lot of behavioral modification technique to burst the stress in the patient. Okay, there are a lot of behavioral modification techniques like adapting the hobbies what they have, doing what they like, and there are so many others. Basically, we go about disciplining the lifestyle of the patient, and this is how we increase the physiological tolerance of the body and the physiological tolerance of the masticatory system. Few exercises I'll tell you here, which can be easily done again by a general practitioner and at the level of dental clinic or the office of the patient or at the home of the patient. First one is the strengthening exercise for the masticatory muscles. There are basically 4 exercises and they are nothing but resisting each movement of mandible, the opening, closing, side to side and protrusion. I go about telling them the neck muscle stretching and strengthening exercises. There are 4 different exercises which I tell them, which takes care of all the muscle stretching and strengthening of the neck. Similarly, these are the posture improvement exercises. So the back muscles stretching and strengthening exercises. This also is very important, and I always incorporate them along with the other exercises. This helps to strengthen our musculatory system or musculature. Okay, so there are 5 different type of exercises which I tell in this section. Once we are done with all the treatment modality, we send the patient. Then comes the most important part, the follow-ups. It is extremely important to do follow-ups. Usually I do 4 to 5 follow-ups over a period of 1 month. And the most important thing which helps me doing this is visual analog scale. I go about making visual analog scale for each and every symptom with which patient had presented. I make them fill this visual analog scale before the treatment start, and I make them fill it in every subsequent follow-ups to see how is my treatment progressing. Okay, and then I change the treatment accordingly. We also do follow-ups when we are giving occlusal splints. It's very important to observe the changes which is happening after giving the occlusal splints. So to summarize, I have discussed 6 basic concepts of TMDs, 6 decision-making techniques or 6 main decisions which we have to make, 5 tools for making those decisions, and 5 treatment modalities. I believe if you master these 4 techniques, you will be able to treat 90% of TMD cases walking in your clinic. Let me take a minute stressing on this topic, whether this skill of knowing TMDs and managing it is important. I think it is very important. Once you consider TMJ in doing any kind of dental work, you are no more a prosthodontist or an implantologist or an aesthetic dentist. You become a much more complete dentist. It's a skill required to deliver excellence in dentistry. It will add value to your practice. You don't have to refer TMD patients elsewhere. It will increase confidence of patient in you, and you can earn a lot of money. I'll tell you, I'm personally telling you, recently there was a case which was referred to me, a 65-year-old woman who went to a dentist and she had an issue of chronic dislocation of the jaw. So when the dentist started working on that patient, the jaw got dislocated. The dentist got so petrified, she was more scared than patient. She did not know what to do. So she referred the case to me and she said, I'm not going to treat. Now, I was very happy. The patient was a chronic case. There was no pain at all. Second point for me to be happy about is it was a full mouth case. And the third point was she was a very well-to-do patient. So I went about doing my treatment. The jaw used to get dislocated, no issues. There was no problem at all. I knew how to relocate the jaw. After finishing the treatment, I used to relocate the jaw and finish the treatment. That way, I made the patient very happy and I could made my pocket very, very happy. So I recommend that you all start learning, understanding, and managing TMDs in your clinic. And please, please, please don't induce TMDs unknowingly in the patients. I would like to once again acknowledge the entire team of online dentistry for giving me this opportunity. I hope I have not, I think I got carried away and I have exceeded the time. My apologies for that. With the hope that all the listeners now has a better understanding of TMD than what they had an hour before, I take your leave. This is Dr. Deepak Daryani signing off. Thank you all and all the very best. Over to the organizing committee.
Thank you, sir. Thank you so much, Dr. Deepak. It was an enlightening session. Let me tell you, I listened from the start you started until the end. It was so much of clinical tips that you have given. Simple way you have explained it. Thank you so much. So if anybody has got any more doubts, you can put in your chat box in YouTube and Zoom. We can address to that. Thank you so much, Dr. Deepak, sir. It was an enlightening session. We are around 900 participants from all over the world in Zoom and in our YouTube channel. We have around almost 900 plus participants at one point of time. Thank you so much, sir. You are like rocking. Thank you so much.
My pleasure, sir. It was my pleasure.
Sir, can you explain the deflection and deviation difference? It's from Zoom platform. Dr. Priyanka has asked one question. Sir, can you please explain between deflection and deviation difference?
Absolutely. So, see, the deflection is a situation wherein the mandible moves only in one direction. Either it goes on the left side or it goes on the right side. This is happening because the disc is getting dislocated. Okay, the disc has got dislocated and it cannot reduce. So the mandible goes only in one direction. If the mandible goes in one direction and comes back to the midline, that is called as deviation. And that happens when the disc which has got dislocated or displaced is able to reduce by itself. If you remember the video which I showed you, it clearly shows how the disc was getting reduced by itself. So disc displacement with reduction is associated with deviation, whereas disc displacement without reduction is associated with purely deflection. I hope I am clear.
Yes, sir. Yes, sir. One more question is, sir, Dr. Shivani Muradi is asking one question: how to relax lateral pterygoid?
Okay. Now this is an art, Shivani. Lateral pterygoid muscle is the muscle which helps in the opening of the mouth and in the protrusion. Now what you do is, I will not be able to share my slide again, otherwise I would have shown you. You can hold the mandible and simply push it posteriorly, little bit down and posterior. Once you do that, you will stretch the lateral pterygoid muscle.
Great, sir. Sir, one more question from O7 Funky Monkey from YouTube. Sir, can T-scan measure dynamic eccentric occlusion?
Dynamic eccentric. See, what is T-scan? It's simple. It's a sensor. So once the teeth comes in contact, it tells you the exact point, exact prematurity. For example, you have done a restoration and it is high. It will immediately tell you, it will the first tooth which will come in contact. So it will give you the exact biometrics where which tooth is coming in contact, what point of the tooth is coming in contact, and what is the force applied. And then you can use this data to trim that tooth or to reduce that tooth to eliminate those high points.
Fine, sir. Sir, Dr. Anup Matthew is asking capsulitis, synovitis, and disc displacement with reduction. How can we differentiate clinically?
Very good. Okay. So, see, Dr. Anup, there is a procedure called as extra-auricular examination, okay, wherein you take your pulp of the finger and you palpate the TM joint region. When you are palpating the TM joint region and it is tender, patient is telling when I am pressing and it is tender, patient is suffering from either capsulitis or synovitis. You cannot differentiate between the two. Only way you can differentiate between a capsulitis and synovitis is by taking an MRI. What was that? Was the question, sir? I think I was able to solve this.
Yes, and displacement with reduction.
So this displacement with the reduction is very easy. When you are inspecting the patient, the jaw is going to one side and reducing. That means the disc displacement with reduction. If it is going only on one side, it is disc displacement without reduction.
Great, sir. So one question is, sir, please repeat tool number 4.
Tool number 4. Okay, the concept of end feel. Okay,
Yes,
it is
yes.
what you feel. A patient has come to you with restricted mouth opening. Now, what is that mouth opening restriction due to? Is it due to a soft tissue like a muscle, or a hard tissue like an articular disc, or a bone like in arthritis? So tell the patient to open the mouth as much as he can and use your 2 fingers to open it little bit more. If the play happens, if you are able to open that, that means the soft tissue is causing the obstruction. Okay, the soft tissue is restricting the movement, and the soft tissue is the muscle. So this is how you differentiate between intracapsular and extracapsular disorders.
Joby, can I take a question?
I just request all the people who attended on the WhatsApp group and the Zoom, please criticize, please tell what you felt. I can see, thank you, thank you, thank you, thank you. That is done and gone. But onto the 40 WhatsApp group, please come and tell how we explain so simple way of TMD, so that we can even request him and beg him and come another next one more week after that. Sir can again come and he can explain so meticulously and simple way. He will do that. If I request, I will oblige, because that's what the relationship with me and Dr. Deepak Biryani, sir. So please come to the chat box and please say how you felt, how you do you want a repeat session of this. He will oblige it, because it's an amazing session. It opened a lot of points, simple way. So please come to our WhatsApp group where you are enrolled and tell whether how you felt about this 45 minutes to 1 hour session. Dr. Binu, you can start.
Joby, there's one YouTube question from Dr. Hinal from South Africa. How can one manage night bruxism in children? Is it possible that the bruxism can prevent the exfoliation of primary teeth due to the forces acting in the opposite direction?
I am so glad she asked this question. You know, there are so many patients who comes to me saying that my child, the parent says that my child is having bruxism. What should I do about it? Please don't do anything about it. You cannot give a night guard to a child. The moment you give a night guard to the child, you're obstructing the skeletal growth of the child. Tell the patient he will grow out of the bruxism. Don't do anything. It will not do any harm. If the permanent teeth erupts and the skeletal growth is over after the 12 years of or 13 years of age, then you can go ahead and give night guard or whatever splint. But you cannot give a night guard to a child whose skeletal growth is still underway.
Dr. Deepak, many are asking for a retelecast of this. That means, if with your permission, we can put that in YouTube. We can do that later. We will discuss about that later. Let's look at the recordings and we will take that decision later. And many are asking for a 3-hour, 4-hour longer sessions on this, because everybody understands that this is not possible to cover in such a short time. Guys, let me tell you, we are already discussing with Dr. Deepak on a full-fledged program under the banner of online dentistry on TMDs. We are planning it in such a way that we had a long discussion with Dr. Deepak. This is not going to be just Dr. Deepak. We are planning to have including myself coming in on basic anatomy of muscles of mastication, basic anatomy of what is disc, what is retro disc. We have to know the basic anatomy before going into big things. Dr. Deepak, I even saw a question just now. Can you explain what is disc displacement without reduction and with reduction? So that is the basics we are talking about. So we got to have, like we discussed last week, Dr. Deepak, it's confirmed. If we are doing something, we got to have a long session, maybe a 1 day, 2 day, a split up session where basics are covered and then comes to the real TMD thing. What do you say, Dr. Deepak? We should definitely plan something like that. It is there in our agenda, guys. We will do that. Dr. Deepak, if you are ready, we are ready to go ahead and do a full-fledged, what do you say, 2 day, 3 day program on this topic. Yeah, we should do.
Sure, sir. I am okay with that.
We should do. What is meant by reduction? See, these are questions coming in. What do you mean by reduction? You want to just cover that quickly, Dr. Deepak?
Sure, sir. Reduction is not, see, if a condyle gets dislocated, you reduce it. Okay. If the disc gets dislocated, you reduce it. Reducing means it is coming back to the normal. If it comes back to normal on its own, it is disc displacement with reduction. Okay, if it is not able to reduce, if it's not, the disc is not able to come back to the normal, it is disc displacement without reduction. I can show them the video, but I don't think we have
Dr. Hafiz. Dr. Hafiz, I'm sure you attended my session on TMD where I had a small, cute little thing made by my daughter. Remember, Dr. Hafiz, you asked the question, that is this disc while moving. If it goes like this, it is okay. But if the condyle is here and goes like this is without reduction and this is with reduction. So this is a basic movement of the condyle we are talking about. For that, we have to know what is the articular disc. Where is this disc attached to? How does it move in a translation movement? How does it move? We got to look into basics here. Right, Dr. Deepak, we have to start from basics, right? From each attachment of the articular disc, blood supply of the joint. That's the way to go. Any courses on TMD? Yes, we are planning that. That much we can tell you. We are planning that.
Yeah, Dr. Binu, can you take one question from YouTube? Tenzin Wozer has asked one question. What about TMD in edentulous patient?
Oh, very, very good question. I had a patient who had edentulous, who was edentulous and who was wearing a denture. Okay. She came to me with TMD issues and I had no literature about it because I had to increase the vertical, dimensions. I have to give a splint, but how to give a splint? She's wearing a denture. I actually went ahead and fabricated an occlusal splint on the mandibular denture and it worked wonderfully well. With all the 4 therapies which I told you, we can also give an occlusal splint over the denture and relieve the patient.
Oh, great, sir. Great. That's great. Sir, could you please repeat about separators on muscle action? Dr. Anchita UK has asked one question, sir.
The use of separators. Okay, separator is a wonderful device. What is it? Nothing. It's a device with which we prevent the complete closure of the jaw. Okay, I use ice cream stick as a separator. Now, why do we use it? Let me tell you that lateral pterygoid muscle is not a single muscle. Actually, the lateral pterygoid muscle has got a superior head and an inferior head. They both act like 2 different muscles. The superior lateral pterygoid muscle acts during the power stroke. For example, when you bite, when you chew, the superior lateral pterygoid is not working. But when you chew hard, you give that power stroke, that time the superior lateral pterygoid muscle acts. But the pain can be elicited either from the superior lateral pterygoid muscle or from the intracapsular, where increased pressure inside the capsule. Okay. How to distinguish between the two? You use a separator. When you use a separator, the superior lateral pterygoid muscle will not completely contract. And hence, if the pain goes away, that means it was the superior lateral pterygoid which was involved. If the pain doesn't go away, that means it was the intracapsular disorder which was causing the pain. I hope I was
Yeah.
clear there. I
Great,
don't
sir.
know.
Great, sir. Great, sir. Dr. Dibali KJ is asking one question from YouTube. Sir, I came across a patient of 45 years of age, female patient who has given night guard slash splint for mild trigeminal neuralgia. She came back with cervical abrasion of lower posteriors. Any correlation with splint, sir?
Correlation of splint with what? With the trigeminal neuralgia, there is no correlation.
The
There is no
cervical
correlation
abrasion.
between trigeminal neuralgia and splint. We don't have to give splint in trigeminal neuralgia, number one.
She
If she's
came back
asking
with cervical abrasion. That's what she asking.
cervical abrasion, I don't, unlikely, because unless that patient, the extension of the occlusal splint is at the level of the cervical 1/3, and the patient is trying to remove and put it at a single point. Probably that can little bit do something. Otherwise, I don't think it is related.
Okay, sir. There are two questions regarding into clinical application of a splint, sir. One person is Dr. Faisal Fas is asking, occlusal splint wearing time, how much it should be? And Sarah Cherian is asking, can you please explain delivery of heart splint? How to deliver a heart splint?
Both are very good questions, but it requires more of knowledge here. The first question is how long you should use an occlusal splint. Depends upon what type of occlusal splint you are using. If you are using an anterior positioning appliance, beware. Every 5 days you have to call the patient and check whether if there is any issue coming. So I will not recommend you an anterior positioning appliance for more than 4 to 5 days, maximum 15 days. As far as the stabilizing splint is concerned, it is, if you have made it perfectly, if you have learned the art of making a perfect stabilizing splint, you don't have to bother. You give the patient to him, and there is no problem which is going to happen because we have stabilized it, number one. Number two, all the functional cusp of the opposing teeth are coming in contact, so there are no chances of supraocclusion. So patient can use it for as long as he or she wants, or till the symptoms disappear. Once the symptom disappears, you can discontinue it. And good thing about stabilizing splint is they can keep that splint for a longer time. If in case there is a relapse, they can still use the same stabilizing splint. I'm talking about jaw stabilizing splint or muscle relaxing appliance. I'm not talking about anterior positioning appliance or anterior bite planes.
Sir, many of them is, loaded with appraisal, a lot of things. People asking, can you please request online dentistry to please upload this webinar on our website so that we can access it? Sir, it is like appraisal and appraisal and appraisal. One question, just want to ask you, sir, if patient have large clicking sound on one side, how can you manage this condition? Dr. Santoshi Sandu is asking this question, sir, in Zoom.
Okay, it's a good question. I told you that second decision, whether to treat, whether to not to treat. In the not to treat section, I just discussed about the systemic diseases like fibromyalgia and psychiatric problems like anxiety and all, where you should not treat. But remember, there's one more condition you should not treat, and this is that. If the patient has come to you with problem of only clicking, not associated with any pain, don't treat it. You know why? Because the physiological tolerance of the patient is already high, and patient is able to adapt to the changed condition, and she's not, or he's not having any pain. He's having only clicking, okay, only the sound. It's not associated with any pain. Don't treat it. But if patient is very stubborn and you have to treat it, then the only way of eliminating clicking is by giving an anterior positioning appliance. I was not telling this because people will start giving anterior positioning appliance. It's a very bad thing, because you will be repositioning the mandible in front so that the clicking does not take place. Okay, but I will
Exactly.
not recommend that.
Yeah, exactly, sir. Because even I have a click, I don't get treated. That's why. That's why if it's not problematic, leave it alone. That's what. Leave it alone.
Absolutely,
Leave it
absolutely.
alone. Don't complicate it by just giving for the click. Keep it that mind. So there are around 258 questions in Zoom, and around so many questions in YouTube also. This is an amazing topic. You explain it so genuinely and meticulously and simple way. We might require your repeat session, sir. In a week's time, we will let you know if your availability is there, because the questions are pouring it down, sir. Thank you so much. Over to Dr. Binu to conclude now.
Yes, Dr. Deepak, I think this is also my conclusion here that we should have a repeat of this session
Uh,
because just telecasting this live in YouTube doesn't make sense. I mean, you got to be live if it's okay with you. Okay, it's a request. We will come back to you later. We will fix a time. I will let you know much earlier. We should have one more repeat of this and maybe more time to take up the questions because so many doubts are coming in this topic, which is indicating one thing for sure. Nobody has talked this topic so simplified. See, everybody, we, myself and Dr. Joby have attended many TMD programs here. They all go way above the level that we don't feel like asking any questions. So again, this is coming back to the same point, Dr. Joby. We should think about a program wherein we should have a basics covered first, basic anatomy. Then what is this muscle trigger point, palpation, all that with Dr. Joby has already covered multiple times. We will have that all that put together a good capsule, a 2-day, 3-day program. We will definitely work on it. We should have one stuff coming up soon. Dr. Deepak, thank you so much from the bottom of my
I'm
heart
glad, sir. I'm
for
glad. I
such
thought
a
I was running very
simplified.
fast
See,
and I
this
don't have
topic
any.
is so big. A genius is a person who can make complicated things simple. So I really appreciate the way you put this across on a topic of this kind, which is a gray area for multiple specialties, including oral surgery, prosto, oral medicine, you name it, it's a gray area. You have covered it so correctly. Thank you so much, Dr. Deepak. Good night. Good night, Dr. Joby.
Yeah,
My
good night, and come to the WhatsApp group and please do criticize us, tell us how you felt about this. If you want a repeat session, please post the comment, refer to your friends. We can come back. We can request Dr. Dibak to come back for a repeat session. Thank you so much. Good night.
Good night.
pleasure.